Okay, welcome to another episode of Talking Away the Taboo. I am thrilled today to bring you the third in the series of, I believe it's going to be five, with the wonderful organization Jscreen. Today, our focus is going to be on male factor infertility. And I'm actually going to have everyone here introduce themselves and just give one or two sentences about why everyone is gathered here. And then we're going to launch straight into really our story of Paul and Julia and their experience with male factor infertility. And so, Paul and Julia, I'm actually going to ask you, the two of you, to go last because then you can launch right in. Abby, you're our representative from Jscreen. Please introduce yourself.
Sure. Thanks so much. Really excited to be here and for this opportunity. My name is Abbe Golding. I'm a certified genetic counselor and I work in the role as our community outreach and engagement manager. And I will turn it over to our physician representative.
Dr. Moradzadeh, and I think I got that. Tell me about the pronunciations. How was it?
You nailed it. Yeah.
Okay.
My name is Dr. Ariel Moradzadeh. I'm a board certified urologist and an andrology and male infertility specialist. I'm very passionate about all things related to men's health and male infertility and kind of debunking a lot of the myths and bringing down the barriers for the taboos and kind of opening the discussion and hopefully shedding some light on things that can impact male fertility.
We are going to get very much into that today. I'm so glad that you're here. Now we're going to turn it over to Paul and Julia, but actually Paul is a doctor as well, but a little bit of a different doctor. And I was told not to say that, but we're doing it anyway. I'd like to introduce Dr. Paul Kassebaum and Julia Cohen. And the two of them are going to introduce themselves. Go right ahead, please.
So we're actually old friends of Abby, our resident geneticist, and we were diagnosed with infertility issues. And the first thing that happened when we went into the reproductive endocrinologist clinic was blood draws. And the first results back we got were genetic screenings. So our first contact was Abby to help us make sense of this.
Yeah. Right. And it was a path of discovery to figure out what was going on. And we were lucky enough to figure out what was going on. And we were lucky enough to be able to address the problem, to get through the problem and through IVF. We now have a 2-year-old son, and we're expecting a second son this year.
Wow. Absolutely incredible. Absolutely incredible. Some people in Jewish tradition say b'sha'a tova, in the right time, so that everything should be in the right time. It's kind of like a little bit superstitious to wish people a mazel tov when the baby is not here yet. So I'm also wishing you a b'sha'a tova. Hey, can the two of you go back to the beginning and share a little bit more about your story, about how you got, we now know the beginning and we know the end, but I'd love to hear, and all of us would love to hear a little bit more about the middle, because male factor infertility is something that people don't talk about very openly often, and frequently. And we know the statistics. I'm going to let Dr. Moradzadeh speak more about the statistics of what the percentages are of male factor versus female factor and all the different aspects and types and so on. But I'd love to hear from the two of you, your experience. Can you bring us back to the beginning?
Yeah. So if I remember correctly, Jules, just correct me if I'm wrong. But if I remember correctly, we assumed that we're not going to have any infertility problems, and so we went ahead with a genetic screening of both of us to see what the risk factors would be for like the top 500 genetic indicators or so.
I thought I just had to go into the office to get prescribed that procedure where they like clear out your tubes or something, because my sister needed that one. And then the next week she was pregnant. So I was like, okay, it's me. And we're going to go see the reproductive endocrinologist. And then next week we'll be pregnant.
hmm Yeah, so we were doing certain things to prepare to have a family, assuming no infertility problems. And we were tracking your menstrual cycle, and things weren't happening the natural way after several months. And so we decided to investigate whether maybe one of us had an infertility problem, or both of us. So we went with the non-invasive tests first. So I went to give a semen sample to a urologist, and they concluded that I had zero sperm in my ejaculate, uh, and my urologist at the time basically gave that as the diagnosis, and that's it. There's nothing that, and he didn't suggest anything that could be done about it. Um, sort of like I'm not sure if he understood why I was there, um, would, or if I should have been more of an advocate for myself to say, so what should I do? But as I remember, he really basically just gave me his apologies, like condolences. Sorry, you're out of luck.
Fortunately, though, I was seeing a reproductive endocrinologist. I think your semen analysis was through, I don't remember, like a referral from your primary care doctor. But when we got the full workup, it was when we went to see a reproductive endocrinologist for me, who approached us as a pair, and the three of us were a team. And she worked in a practice that also had urologists. So they did a repeat semen analysis that was then like in their practice, and then they referred you to their urologist, who took together your semen analysis results and our genetic screening, and unlocked the key piece, which was that Paul actually had, what is it called? There are two types of what's it called? There's like the scientific word for not having any sperm in your semen. There are two types.
Azospermia.
Yeah, there's well, I'll let you talk to that, but the urologist diagnosed him.
Yeah, so
Finally.
obstructive azospermia is probably what he had.
Exactly.
So you know what? I'm actually going to pause you for a minute and actually turn to Dr. Moradzadeh. So in this moment, when Paul and Julia are talking about, they're going through the initial investigation, they're not getting pregnant. One of the first things you do is you do a semen analysis and all of the different pieces afterwards. Can you take us through that process of the typical patient who comes in, what's being done from a medical side, and then, talking about where they're at in this moment in their story with the non-obstructive azospermia?
Sure. So let me kind of start with every patient that I see for a fertility workup. So I'm going to get a thorough history and a physical exam. You can gather a lot of information just from a history and physical exam, whether it's, for the idea of, like, let's say, bilateral absence of the vas deferens, that coincides with cystic fibrosis, whether someone's a carrier for cystic fibrosis or they have cystic fibrosis. So I'm going to ask things like, were you sick often as a child? Were you hospitalized for any, you know, bacterial or viral illnesses as a child? So like those kinds of things you can kind of gather maybe earlier on in screening with just doing a very thorough history. Also, the physical exam, I'm able to, in some cases, God forbid, but it has happened before where I'm seeing a couple for fertility workup and I examine the man and I actually have discovered a testicular tumor. So I think it's very important to see a trained urologist, oftentimes a reproductive urologist if you have access to one, because they're going to be the ones that have the training to tell you, okay, the azospermia or the lack of sperm in the ejaculate, what is it really from? So in the case of Paul, it sounds like it was an absence of the vas deferens, which is the tube that actually carries the sperm from the testicle and puts it in the ejaculate. So by being able to do a history and physical, you can gather quite a bit of information. Now, there are several things that need to be done in the workup and management of infertility. So is it genetic? So we do genetic screening when there's azoospermia. Is it anatomic? So in the case of Paul, the anatomy, there was a separation or a break in the tube causing the sperm not to be able to go from the testicle into the ejaculate. So
Well,
genetic.
in my case, just to correct the record there, in my case, it was genetic, atypical cystic fibrosis.
Okay. So cystic fibrosis is the type of thing where the genetic component leads to a physical or anatomic manifestation, and that leads to these kind of like skip lesions or skipped areas or breaks in the continuity of that tube that carries the sperm from the testicle and puts it in the ejaculate. And so screening for, things like cystic fibrosis, Klinefelter syndrome, Kalman syndrome, all these things get screened for in the genetic test. And then, so let's talk about anatomy. So the vas deferens, whether it's in continuity or it's not palpable. In the case of Paul, I'm going to assume they couldn't feel the vas deferens on one side or
Right.
both sides.
Right.
Now let's talk about varicocele. So I'm sure a lot of the listeners know what varicose veins are. A lot of people get them on their legs. They're kind of those unsightly veins. They're the result of incompetent valves. So all of the veins in our body have valves. So when you stand up, all of the valves from your feet all the way up to your head, all these valves will slam shut, and they basically prevent all the blood from rushing to your legs and your feet when you stand up and preventing you from passing out. What happens in the case of varicocele, this is an anatomic and probably the most common cause of subfertility or infertility in men, is guys can get these dilated veins around the testicle. And if you imagine, God put the testicles of a man outside of the body because it's about 1 degree Celsius cooler than inside the abdomen. So eggs in a female are inside the ovaries, inside the abdomen, and they're not temperature sensitive. But sperm and the sperm production cycle inside the testicle is temperature sensitive. So God put them outside the body and it's about 1 degree Celsius cooler. But when you have these dilated, engorged veins called varicoceles, so they're basically varicose veins around the testicles, these will heat up the testicles and impact the sperm production and the sperm quality. They lead to impairments in the movement or the motility of the sperm, the concentration or how many sperm are actually there, and also the shape or morphology. So all of these can be impacted by varicoceles. And then kind of lastly, as part of this full workup, is really doing a hormonal management and hormonal assessment. So I like to check the hormones in the pituitary gland in the brain that signal the testicles to make testosterone and promote sperm production. So that's kind of like the comprehensive approach I take to the workup and management of guys that I see for infertility workup.
So it sounds like we saw a regular urologist and not a reproductive urologist the first go around.
Yeah.
That's
Because
what it sounds
actually,
like.
yeah, because the questions and the physical exams that you demonstrated, you would have caught it right away. Yes, I was sick as a kid, often with any upper respiratory infection would eventually lead to me being practically or literally hospitalized. The palpitation test would have not felt any vas deferens. And I was already, as I was alluding to earlier, when we were assuming we weren't going to have any issues having a child, we were already partially genetically screened. And one of the two genetic indicators, showed up in that initial screening. So our journey would have been a lot faster.
But on the whole, compared to probably most listeners, I feel like facing infertility, we were incredibly fortunate to get
relatively fast.
Yeah, I
few
mean,
months.
from infertility diagnosis to pregnancy was less than 12 months.
Yeah.
Wow. That's incredible. That's
I
incredible.
was very lucky.
Wow.
Yeah, and I think maybe we may have lucked out on the first urologist I saw, but we had friends in the medical practice who were able to guide us quickly as well. So,
And
takes
the
a
work,
bunch.
like the journey doesn't stop with the diagnosis. It really just sort of begins. So all throughout IVF, so many genetic questions that come up, and just to have that be in my phone was so fortunate, even though she'd already moved away. We were long distance friends at that point. Um, we've been blessed in so many ways.
Yeah, absolutely.
So this is the perfect opportunity for me to ask Abby some of these genetic questions. Abby, I'm wondering, Dr. Moradzadeh talked about a few different diseases: cystic fibrosis, Klinefelter's, Commons. Like, can you speak about the role that genetics have in malfactor infertility? Because to be clear, and then I'm going to come back actually to Dr. Moradzadeh afterwards, not all malfactor infertility has a genetic basis, as some do, and in this case with Paul and Julia, it did. But Abby, can you shed a little bit of light for us, please?
Sure, absolutely. And I think it is really important to clarify that, right? They happen to be in a situation where they got a diagnosis as a result of genetic testing, but that's not always the case. And we do have to work through that. So when we speak about male infertility, I think it's helpful we can kind of classify it. So we can think about first that the X and the Y chromosomes. And if we go all the way back, right, to middle school or high school biology, one way or one type of infertility can come from when there is a small piece or a micro deletion in which there is missing information from a specific region on that Y chromosome. And that could impact sperm production. So that's one thing that genetic testing may look for. Then another piece of the information that we can talk about has to do with chromosomal abnormalities, where there's too many of them. And Dr. Moradzadeh alluded to that as well, which is just a fancy way. These aneuploidies is a fancy way of saying that there's that total number of chromosomes is incorrect. And so a common one that people may have heard of is Klinefelter syndrome. So that one has sometimes come up, and that's when they're sometimes known as 47XXY. So there's an extra chromosome of the X chromosome there. We can also have what's called a translocation, or a piece of a chromosome has actually physically moved and translocated onto another piece. And so those little breaks in it have caused some of that genetic material to not be in the proper location, and that can impact those messages, and that can also be a cause of infertility. And again, it can be all different types of sperm issues. So it can be azoospermia, as we were talking about here, but it may be that the motility of it, the morphology, all the things that we were kind of alluding to initially when we were talking about genetic causes. And then there can actually be those single gene disorders, or what we call monogenic diseases, that's caused by, a single mutation in a gene. And the most common actually that comes to mind is cystic fibrosis. And typically when people think about cystic fibrosis, or oftentimes it's a lung disease, right? That's what they think about. Oh, I'm having trouble breathing, or I may have a lot of sputum or phlegm in my lungs that's making it different, or I cough a lot. But actually in the fertility space, as we said, it causes that CBAVD, or congenital bilateral absence of the vas deferens. And we have the perfect person to explain that on this podcast with us. But they may have no other symptoms of male factor infertility other than male factor infertility, which may not be noticed until they start to try and expand their family. Paul, though, not that you're looking for the perfect case, Paul, and you want to be this, but when you shared with me, which really we hadn't had this discussion until you were saying, that you were sick as a kid and had all of these respiratory illnesses and things, it kind of puts that picture together of some of these things and until we step back, right? I always think that hindsight's 2020. It really was. Kallman syndrome, another one. So these single gene disorders. So I like to think of it kind of classified like that. And one thing I do want to say is we don't expect these to run in families. It's not typical that when you look back, you're going to see, oh, all these people had infertility. I should have known it was coming. First off, we never want to feel that we're responsible for causing something like this, right? We never want to carry and harness that guilt, but we don't expect to see that also. So because of the way they're inherited, cystic fibrosis or common, you're typically not going to see that. So I hope that gives some context around these conditions. And again, everything being genetic, but not everything being hereditary, meaning they don't always run in families.
I love that. I think that's a really important distinction. And yes, absolutely, there is that connotation. People are like, "Oh God, it's genetic and it must mean," and actually here, no, it actually doesn't. Um, okay, Paul and Julia, I'm actually going to turn back to you. And so, okay, you got this diagnosis. Then what happens?
So the diagnosis actually came with a prognosis. Um, there's I mean, Dr. Moradzadeh will correct me if I'm wrong, but there's only one thing to do in this case, and that's to go into the testicle and with a needle and see if there's sperm in there that just couldn't get out. Um, and Paul's urologist told us again, Dr. Moradzadeh, you'll set the record straight numerically, but we had something like a 90% likelihood of finding viable sperm.
Yeah, that's correct.
Which in the IVF world, that's like winning, hitting the jackpot. Like, of all the things that could be wrong, um, there's a lot of stigma and emotional baggage around male factor infertility. And there's that terror of the 10% that it's not going to work. Um, and then there's the financial aspect. I thought I had really spectacular, I was told I had really spectacular infertility coverage or fertility coverage, a carve out through my health insurance, but it didn't, even though Paul was on my insurance, it didn't cover his procedure. So that was out of pocket.
Mhm. Yeah, and also to add to that, when we had the prognosis from the reproductive urologist, he gave us that statistic, and he was just his affectation. He was he seemed very, very optimistic.
But then there's also that wait, because you can't do the procedure the next day. He's got a schedule. He's got to book you, and you're sitting with that unknown for however many weeks it takes to get the procedure.
Yeah, we were lucky that we could afford out of pocket, but it was a pretty penny. And I thought it was curious that it seemed like the insurance system maybe has a bias,
right?
That infertility is a woman's problem, so we'll cover it. And I don't know if I don't know if it's an omission or not looking at the health statistics that part of us making sense of things. We were trying to read the statistics on this, and why is male factor infertility not covered?
Abby, you've said it's a third, a third, a third.
We
So explain, what is that? What do you mean by a third, a third, a third?
Well, and Dr. Moradzadeh, correct me, but we often think it's a third female, a third male, then a third kind of unexplained. But what do you see in your practice? I mean,
Yeah, I would say probably about half the time it's a female factor. Maybe 45% of the time it's a female factor. About 40% of the time it's a male factor, and then the 15% is like unknown. I mean, there's like unexplained infertility, which I'm gonna kind of get to, but I can even talk about it now. But even with all the workup of doing the genetic testing, the hormones, the anatomy screening, ultrasounds if needed, physical exam, all that stuff, there's still a subset of men who I don't have an explanation as to why they have either no sperm in the ejaculate or low sperm count. So there is a kind of a basket of unknown infertility or unexplained infertility. And the only way to really talk about that is, could it be like an environmental factor? Could it have been, is it the microplastics, these hormone disruptors in the environment? Is it some kind of environmental factor that we can't account for? Or is it some like unknown genetic test that we just haven't developed the screening tool for? So I think with time and the advent of AI and all these different kinds of technologies, yeah, maybe that basket of unknown infertility will get smaller because we'll eventually be able to compartmentalize and kind of identify different factors that lead to infertility. Now, going back to Paul's case real briefly, um, patients say, well, why can't you just, reroute or reattach the segment of the vas deferens that's interrupted? The thing with congenital absence of the vas is that it can also occur in like skip lesions. You can kind of bypass one area, but there might be another area downstream on the way to the ejaculatory duct of the prostate. So in the case of Paul, the only real option for a patient who has azoospermia and absence of the vas deferens is to do what's called a testicular sperm aspiration, also goes by the name TESA, TESA, which is a little different than a testicular sperm extraction called a TESI. And that's kind of for different factors that lead to azoospermia. But there are a lot of ways that you can give prognostic factors by checking the hormones, for example, because the hormones will tell you that the signal coming from the pituitary gland going to the testicle is actually being received. And it kind of gives you a hint that, okay, sperm is being produced, but in the setting of Paul, it's just not able to get out of the testicle. Even like, for example, a testicular biopsy, I'm sure you'll see tons of sperm in someone who has a congenital absence of the vas deferens. So either you can aspirate the epididymis to get the sperm out, or you can do a small testicular biopsy. But most often you find sperm in these guys.
Can you just spend another minute here and give us a window into if it is not obstructive azoospermia, what are the other possibilities for if someone has male factor infertility?
Yeah, so it could be something like Klinefelters, for example. Um, you got a lot of FSH being released by the pituitary gland, the follicle stimulating hormone. It's trying to tell the testicle, like, hey, make sperm, but for some reason the signal is not being received by the testicle. So a high FSH portends a poor prognosis because that's the brain, the pituitary gland, trying to signal the testicle like, hey, make sperm, and it keeps sending more and more signal. But if it's not being received for a multitude of reasons, then the factory just can't produce the sperm. There's also something called like microobstruction, and this is another one of those like unknown infertility factors where someone has a normal FSH, they have azoospermia, they have a palpable vas deferens on both sides, but they just are not having any sperm in the ejaculate. But more oftentimes, I would say about half the time, actually, we can do a TESI or that testicular sperm extraction and find sperm for those guys. And then the other 50%, it's an unfortunate cohort, but um, you try your best and pray and hope to find sperm on the day of the retrieval.
Yeah, I mean, I've personally dealt with many patients, clients, however you want to call them, who they have no sperm and period. And looked, they've had a number of different procedures and over a course of a number of months or even a number of years, and there really is nothing. And their only options are using donor sperm or adoption, frankly.
Mhm.
But that was not the case here. So let me actually turn back to Paul and Julia. And okay, so you had this procedure done, and
Yeah, and
Cries of relief. And it was a success.
right. First was the aspiration for me, and the doctor telling us that yes, we did find enough healthy sperm to put it on ice for IVF, and then we um, set up Julia to prepare for her IVF procedure as well.
So there's crossing your
turns.
fingers every step.
Mhm.
Yeah. My RE even told us that she had tried IVF because they wanted to try for a girl. And she had a terrible experience with it, even though she'd already had two boys. And so it's just, you think about the miracle of life the old fashioned way, and there's a miracle of life the scientific experimental way too. We just got lucky because it's rolling the dice at each step of the process.
Mhm.
A lot of needles.
Yeah, for Julia,
Right.
yeah, to do the egg extraction and then implantation
Yeah.
and so on. Yeah, the typical IVF's typical but positive IVF story from there on after my surgery. Yeah.
Paul, can you share a little bit about your what you personally went through in
Mhm.
terms of hearing that this was, quote, your fault? I mean, I
Yeah.
hear a lot when I'm dealing with patients and, that shame, that guilt, that, this was something that I did, this is something that I caused. Um,
Yeah.
how you dealt with it, how the two of you dealt with it. And then I'd love to come back to you, Dr. Moradzadeh, and how you manage these patients from an emotional standpoint. And when they're getting these diagnoses, sometimes very difficult results where you don't have any hope for them. Sometimes you do, and sometimes you don't. So, Paul, I'd love to hear a little bit from you, and also Julia, about how being on the other side of this, and this is the person that you married for life, and like then seeing this person so bereft, and I mean, I'm now putting words in your mouth, Paul, but just having to hold someone with these kinds of emotions. I'd love to hear how the two of you really moved through it and were able to
Yeah.
work together.
Sure. So there was that initial phase of not knowing, just having the diagnosis of having no sperm, and that's that. That's the end of it. And I thought, um, um, I felt guilty for messing up Julia's expectations of having a family with me. Was hemming and hawing about whether I would be emotionally willing to adopt. I thought that might be our only option. And there was also the feeling of being less than a man, being completely. I thought at first I was completely infernal, and um, feeling uh, like analogous to, like, I'm not a very muscular guy, right? So I'm used to, I've in the past I have felt less than a guy because I'm not muscular or not athletic. But this felt akin to that, but more fundamental, because on the athleticism side, there's something I could do about it. But early on in our discovery, I didn't think there was anything I could do about this. So it was like this sort of feeling less manly in a more fundamental way than the lack of being athletic. Later, when we learned that there was something we could do about it together through aspiration and IVF, I had a different sort of guilt for a while about putting Julia through the arduous process of IVF. If she had a different partner who wasn't infertile, she wouldn't need to go through IVF. So I sort of felt like this is my fault that she's going through this. What to me would seem like a very big ask. Um, uh, but Julia was a very supportive partner, and mollified me and said, no, that this is not some, you don't have to feel guilty about this. If we're going to have a child by this process, what's a few dozen needles compared to giving birth, which is probably infinitely more.
And then compared to the bedtime routine and trying to tie a toddler down to brush their teeth.
Yeah, so just a blip. These needles are just a blip.
Which one is worse? I mean,
yeah. The needles, at least I knew, would end eventually. We're just crossing our fingers that our kid acquiesces teeth brushing eventually.
Yeah, and when I was dealing with the sort of emasculated feelings, I was able to turn to a few friends of mine, other men, who, once we started sharing our infertility discovery journey with a few close friends of ours, we learned that, just as the statistic says, this is actually more common than I thought ahead of time. And sure enough, as I was sharing our problems with people and my emotional challenges with guy friends of mine, I learned that some of my guy friends were having problems too, and having the same feelings about being less than. And it's kind of easier to tell a friend how to cope with these sorts of feelings than it is to tell yourself. And so, one friend in particular, we were able to, I think, externalize our problems through each other and helped each other emotionally to feel like, no, we're still men. And there's um, these other aspects of being a man that are still important that we recognize ourselves as important. And saw it in each other. So we're able to help each other get through it. And I know as a guy myself who doesn't talk to his friends very often, um, I know it can be hard to pick up the phone or ask a guy friend of yours to grab a drink, to have a chat. But that that sort of um, that sort of connection with another male friend who not all of them had infertility problems, but were still very helpful to me and supportive for me. Um, Reaching out to your other guy friends, you might discover something interesting about them, learn more about them, and not just get help to yourself, but you might find yourself in a position to help them as well. Um, yeah, and then um, as we learned more, I was still updating those friends of mine, and they were going through their own journey. And Dr. Moradzadeh was mentioning some factors that I recognized through my other guy friends who had their similar, those exact problems, different than mine. Um, and now some of my friends have found that they can't have children, and have become honorary uncles to my kiddos.
That's beautiful. That's beautiful. Thank you for sharing that. Dr. Moradzadeh, how do you manage these patients emotionally? I mean, obviously, your job is the medical realm. You're not a therapist, or at least as far as I know, it didn't come up in your bio. But you have to hold these people. You're giving very difficult diagnoses to people. I mean, I'm guessing that if people land on your patient roster, it means they already know there's something going on. They just don't know exactly what that is. Um, talk to us a little bit more about that piece of it, please.
Yeah, so by the time a patient comes in or a couple comes in to see me, they already have an idea as to, okay, there might be a male factor um, at play here leading to the subfertility or infertility. The thing to keep in mind is patients coming in think it's only them, but I always normalize it for them and have to explain, I've by 10 a.m. already seen a couple patients and, some of them are infertility patients. So, I think normalizing it for people and making them realize like it's more common than they think. And a lot of their friends or people in their friend circle are either some of my patients, which I obviously don't tell them, but I just say, it's more common than you think or than you know, and just normalizing it for them so they don't feel like they're alone in this journey. Um, this journey can be very difficult and challenging. Like Paul and Julia were saying, lots of needles for the female side, and there's like this whole unknown of is the 90% prognostic factor really going to be 90%, or am I going to fall into that 10% category where there's really no sperm? So there's like this fear of the unknown, but I think half of my job is being a therapist in a lot of ways, normalizing things for men, whether they're seeing me for erectile dysfunction, low testosterone, fertility issues. A lot of it just has to do with telling them, look, you're not alone. I see many men throughout the course of the week who have very similar issues as you, but we're going to figure this out together. And I always tell patients, my job doesn't end when I'm done with the surgery. The surgery can go perfectly smoothly, but my job ends when we get you the end goal, whatever the end goal is, whether it's having kids or having better sex life and all these different things. But I think normalization kind of goes without saying, and kind of giving the patients the comfort and understanding that the you're not alone in this journey, and you will encounter other people that will go through this, and you'll be able to help them by explaining to them and kind of comforting them with what you guys went through.
And if I could jump in, I think there's also something beautiful about when you get an answer, there's something you can do about it, right? I think that, there's a lot of fear around this. And obviously, my heart just swells that they were able to fall into those statistics where things worked out. It's also a little ironic because they both work a lot with numbers and would always ask me for percentages and probabilities, a lot. So, when your friends are the patients that you would never want because they love those odds so much, you're just like, come on, guys. But it having an answer in a genetic explanation, I think also can empower individuals to say, now I have this, and if I want to use this to do something about it here in this case, right? Paul was saying, well, this was the only answer, but there is something you can do about it, right? And so you can then work with someone and move that forward in a way that you may not have just kind of been sitting in the space of saying, why, but also then getting that support, Paul. Knowing you, but this is huge to be able to talk about it and to help empower others and to teach individuals to be an advocate. Even just to make the appointment with the physician can be huge for some people. So just, thank you for finding it within yourself to disclose this, because it can be such a state of vulnerability, but make such a difference for someone else, and maybe the family that they hope to one day have. So thank you. Both you and Julia. Thank you.
1,000%. One last question for you, Dr. Moradzadeh. I know you're on a very tight schedule today. I'm curious if you could give people a window into the time frame that from the time that they walk into your office and they have that first appointment of where the discovery, so to speak, happens to, let's say, Paul's case specifically, and where, okay, it's non-obstructive, specifically he had absence of his vas deferens, that tube that connects one to the other, the procedure, like what's the time period? Just so people, like we know with Paul and Julia, from the time that they sort of thought there might be a problem to the time she was pregnant was about a year. Is that common? Does sometimes things take much longer? Can, share with us a little bit about that?
Yeah. So for Paul's case, the obstructive vasospermia, like he had this blockage and the vas deferens was not in continuity. I would say on the whole, there are a couple factors that need to fall into play. Has the female partner seen a reproductive OB? That ends up adding on like a month or two because it takes time to get in to see a reproductive OB. So, have they been evaluated yet? Do they need a referral? Okay, for the example of someone like Paul, they're going to need a sperm aspiration. Are we going to do it on the day of the egg retrieval? Are we going to do it beforehand and freeze the sperm? So there's some like logistical things that need to be factored in. I would say things don't happen overnight. This is going to be like a several month long period. So I think having the idea or understanding of like, God willing, being pregnant within a year, I think it's definitely on target.
Okay. Okay. No, that's helpful. I think sometimes, we all know with the fertility process, at least those of us who are in this world or have been introduced to this world, Paul and Julia, we know that things are not instantaneous, but also thinking like, okay, this, in all good scenarios, if things go perfectly, this could be like, it's not endless amounts of time and years. This could be
Correct.
all kind of wrapped in a bow, again, if all things go well, in a somewhat reasonable amount of time. Um, okay, I deeply appreciate. Thank you so much for being here.
My
Um,
pleasure. Thank you.
Thank you, Paul and Julia. I'm going to actually come back to the two of you, and Abby to kind of also close us out here. I would love to know from all of you about your advice to other people who are just starting on this journey. This is a really intensely emotional journey. Like as both of you said, you never thought you were going to have any problems. Paul, I'm curious if even your parents, sort of looking back, if once you told them what the story was, I imagine there was, oh yeah, you were sick a lot, but no one ever thought. It was a day and age where no one would have ever thought that there may be something more going on. But for people who like think they're just going to have a baby when they want it, and then things don't happen that way. What advice would you give to those people, especially here, because today we're here talking about male factor infertility? What advice would you give to those people? And I'm going to point the question and ask it to you, Paul, and then Julia, for you to answer. What advice would you give for the partners of how to support your partner as they're going through this? And then Abby, I'll turn it back to you when people to kind of close us out.
Absolutely.
Yeah. So I would say, um, I think it would make sense for folks to get a sort of fertility screening when they're relatively young, in their 20s or so. When you're doing family planning, I think a lot of people are comfortable doing it in their head, saying like, I'm going to not have children until I have this or that education. Okay. Well, you might get to a stage where your natural fertility has dropped significantly, and you think it's going to be a piece of cake to have that child now. But if you had only known earlier that you had a particular infertility, maybe you could have done something to enable that plan that was in your head, and have the biological planning as well as the socioeconomic planning in place. Um, the Another thing I would say to men in particular is to um, to really, if you find yourself in a situation where you have um, enough information to know that you have male factor infertility, and then you're on that sort of spectrum of that's all you know, you don't know the full picture. That's, for me, a critical thing that got me through what was initially, for a brief period, like sleepless nights and um, dread, was really reaching out to my friends, my guy friends. And as the doctor was mentioning, he likes to normalize, put things into context for his patients. You mentioned I'm Dr. Paul Kassebaum. I'm a physicist, not a physician, but my first instinct was to look through the scientific literature. And the first thing that hit me as um, surprising was the statistics of how many men in the United States are found to be infertile. And that's like found to be infertile. So it's like a minimum. There's all the other folks who don't know they're infertile, right? So I was actually very shocked at how high that percentage was. I think it was, correct me if I'm wrong, but I think it's something like 20% of men have known infertility. And so right away, that made me feel a little bit less of an outlier, you know. Like I mentioned earlier in the podcast, I had different sorts of feelings of not feeling like a man, different meanings behind what does that mean to not be a man. But if 20% of men are just like me, okay, I'm not a complete weirdo. So that scientific literature context helped me. If you have a great doctor like Ariel on your side, he'll put it in context for you sooner than I was. And then to reach out to your friends with that such a high percentage. Some of your friends might have male factor infertility, as indeed some of my friends did. And just talking to them about it really, really helped me emotionally. And the other advice I'd give, I guess, would be
I'm thinking back to what you said, Amy, at the top, in place of congratulations, with our news of number 2 on the way.
Mhm.
Everything in due time. God willing. Those are my words, not yours. But even with the IVF piece, like some folks will get pregnant the old-fashioned way, and it'll take them a year or 2 years or goodness knows how long, but all in the right time for them. And then in our case, with the IVF piece, I mean, Dr. Moradzadeh said 12 months is a reasonable benchmark, perhaps. But when we got the diagnosis, I was all go, 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 and thinking, okay, my cycle being once a month and Paul's procedure coming up a month from now, we can be pregnant within 2 to 3 months. Then life happens, just like it happens for folks who aren't dealing with it. So I'm sort of taking the mic from you. But life unfolds differently for each of us. And I just love, can you say that? Can you say that expression?
Bisha'a tova. So it's Hebrew. It's Hebrew. So sha'a is time, and tov is good, and beh is the in. So in good time.
I took a year and a half of college Hebrew, but I don't.
I took 3 years of high school Spanish, and I remember very little of it. So
Actually, I remember now another piece of advice, which is get a second opinion.
Yeah.
If you get a diagnosis, don't stop till you get a prognosis. So when we got that diagnosis from the first, perhaps non-reproductive urologist, that was enough for me to winnow down the possible problems just through looking at the scientific literature. Right, it's sort of like a early on in my process of figuring out what could be going on with me. There's a fork in the road. Do you have literally zero sperm in your ejaculate or non-zero? Right, and then that immediately winnows down the possibilities, right? And so I saw in the scientific literature that there were conditions that were treatable, and so even before we got a better doctor, I started feeling a little bit more hopeful.
But the whole of it is just brutal. I mean, part of why we were pregnant within 3 months, and IVF clinics will close for a week or 2 weeks every year seasonally to make sure all their admin and labs are in order. And then emotionally, it's just devastating, the weight, the unknown. I mean, even once the ball is out of Paul's court, so to speak, there's all that unknown in the steps of the egg retrieval and then embryo development. It's grueling emotion, the whole of it. It is not fun. But and that's also part of why, like, we took a break from in between the steps along the way. That's all because we needed to recover emotionally before we went. You're talking about creating human life. You want to be as close to your best self as you can imagine before you endeavor down that path. So there's lags there, but
it's exactly the reason why I was supposed to have a baby exists, because
I should have known about it.
You do now.
I do now, yeah.
No, it is.
Well, we've been advocates for things that we've learned along the way, right? So
right. We've told friends, get yourself a workup. You're thinking about maybe wanting to be a parent someday. Talk to your doctor. It doesn't. If you've got health insurance, it doesn't take a whole lot to get the workup. So, information is power.
Absolutely. Abby, your thoughts as we close this out?
Yeah. I mean, what you guys have shared is so powerful and so important to the community. But I think I just want to say it really does take two sets of DNA to get pregnant, right? I think it is so common, and we just talk about the woman in the situation, and the other person is along for the ride, but both sets are just as important, and so we want to make sure that we're thinking about that. Ideally preconceptually, right? So, and Paul said is in advance so that you have that information, but also that time and space to process it, right? Julia, there's a lot here. And so when you give yourself that ability to step back and say, what is it that we're going for? What do we want? Who do we want around us? When do we feel comfortable sharing about it with not as such of a rush timeline that can feel really different, and that no one should feel shame about this and the efforts that it takes to get pregnant. It's really important. No one asks for this, and we don't have any control over our DNA. And Paul, you kind of hit the nail on the head before when you were like, I tend to be a lot kinder about what I tell someone else than what I'm telling myself, right? And I think it's important that we keep reiterating this, because the more we say it out in the universe, hopefully the more someone else will hear it, but the more we'll listen to ourselves as well. It's so important. So I think I'd like to leave with those two thoughts. And then just the biggest thank you for sharing your story with us, and all of talking away the taboos listeners, because I know this will touch the hearts of many.
Absolutely.
Our pleasure.
Absolutely. Paul, Paul and Julia, the two of you are really, I'm deeply indebted to the two of you. This is a topic, as I said earlier, Abby said, we all said, this is a topic that people often don't like to talk about because the assumptions are that it's a woman's issue, and men often are not open about the difficulties that they're going through, especially even emotionally, what they're dealing with. And so by you sharing, the two of you sharing here, you have effectively and beautifully normalized so much for so many people. So I'm deeply grateful. Thank you so much.
Thank you.